and it is more liable for seizures. So because of immaturity, they have more chance of seizures.
I presume everyone is able to see the screen well and we are audible well?
Yeah, sir, you have to share the slides.
Okay.
Screen is visible. You have to stop this and share the slides.
Okay.
Presentation.
Yeah, your screen is visible, Dr. Sanjiv now. Your
Okay.
slides are visible, Dr. Sanjiv.
So I'm going to talk on neonatal seizures. So incidence is highest and morbidity, mortality is highest in neonatal seizures basically. Because of there is a lot of immaturity of the brain, and because of maturity, it is more excitable. That's why they have increased chance of getting seizures. So this graph is showing maximum incidence in neonatal age. So what is more harmful? We do get a lot of patients present with prolonged seizures, maybe status, or patients who can present with recurrent seizures. So prolonged seizures can lead to neonatal death, but fortunately it is more common in adult, and neonatal brain is more resistible to neuronal death. So in neonates, it is recurrent seizures, may not be prolonged, but frequent seizures are more damaging to the brain, and it is associated with long-term functional, morphological, and physiological deficits. So which are the mechanisms which leads to brain injury because of recurrent seizures? So it leads to disturbances in cerebral blood flow, which may increase or decrease. There will be problem with the energy metabolism, decrease ATP and increase ADP. Also, there is change in the homeostasis of excitotoxic amino acids, which increases. There will be difficulty in neurogenesis, and finally synaptic reorganization, which can lead to a lot of cognitive impairment and epileptogenesis in their later life. So this is the seizure classification. We should know which kind of seizures we do get. So it is clonic, which can be focal or multifocal. Tonic could be focal or generalized. Myoclonic can be generalized, multifocal, or even focal basically. Subtle seizures are like ocular phenomena, orobuccal lingual movement, others like apnea, autonomic seizures, autonomic changes, and only limb movement. This is very important. Sometimes this can help us in thinking about the etiology and prognosis about the future. So apnea is possible as a seizure in neonatal age group, and it is common in term neonates. Usually premature infants doesn't list presence with seizures as apnea spells as a seizures. So whenever premature infants presents, you think about the apnea prematurity or other reasons, but not the seizures. So term infant exhibits other phenomena along with the apnea. So look for eye opening, staring, some movements of the eyelids, mouth movement, so which can indicate this is more likely to be a seizures. What about bradycardia? Commonly we see in premature apnea prematurity, but here usually you don't get the seizures unless seizure is lasting for more than 60 seconds, which is bradycardia is there. It is secondary to cerebral hypoxia. I'm going to show slides about the subtle seizures. This is cyclical movement of both the lower limb. Then these are lip smacking, very well appreciable in this video. This is a tonic eye deviation. Sometimes they can have changes in the pulse rate, changes in the pupillary size. So autonomic changes can be there. This is a video of kicking. Again, subtle seizure. There is mixed seizure here, but it is predominantly nystagmoid movement. Now it is visible in both the eyes. Sometimes you need to be very good observant. So another manifestation of seizure is clonic seizures. Focal and multifocal more likely. Generalized is less common. This is a focal seizure, right upper limb clonic movement. In child is absolutely alert and conscious. Many times focal clonic seizures usually they remain alert. This is a patient with HI presented in 3 hours with these multifocal clonic seizures. So it is not very synchronously affecting both the upper limb or both the lower limb. So it is multifocal in nature. So clonic seizure, focal uncommon, generalized is more common. When they present, it can mimic generalized clonic seizure can mimic decerebrate or decorticate posturing. If it is associated with autonomic phenomena, like I told, bradycardia, tachycardia, or dilation of the pupil, it can be easy to differentiate from the decorticate and decerebrate posture from the seizures. So generalized clonic seizure. Myoclonic seizures, again, could be focal, multifocal, and generalized. Can be confused with clonic seizures, but here movement is faster as compared to clonic, and there is a predilection for flexor muscles involvement in a patient of myoclonic seizures. Whenever they get myoclonic seizures, they can have very bad epilepsy syndrome or bad etiology for the myoclonic seizures. So be careful. So which are the whenever we see the any abnormal movement, we need to think about the seizure mimic also. So which are the movements which occurs in an awake state, which looks like a seizure? That is the robbing eye movement, nystagmoid jerks, at extreme horizontal movement of the eyeball. Sucking, which can mimic as a seizure. When they go to a sleep, they can have fragmentary myoclonic jerks, maybe multiple, or it could be a single generalized myoclonic jerk on awakening from the sleep. Sometimes some abnormal eye movements also can occur in an active sleep that we see in few videos. This everybody have come across right and left. It is a benign neonatal sleep myoclonus, onset in the first week. And episodes, it can be bilateral, focal myoclonic jerks, and often repetitive. But it always occurs in sleep. EG and intel EG will be normal. It resolves within 2 to 4 months. Still is at sleep. So these are focal sleep myoclonus. Similar kind of, but different if you look at carefully. So child is at sleep, and there is definite jerk of the left upper limb. Right upper limb is not visible very clearly, but doesn't look like it is involved. So here it is affecting the left upper limb. If you see the same seizure a little bit later, child has started crying. So child is awake now. Still, this movement is going on. So this is not sleep myoclonus. This is a focal clonic seizure, and patient had stroke. So be careful about the seizure mimic. This is a common scenario: jitteriness versus seizure. If you see any abnormal eye gaze or eye movement, then it is seizure. Autonomic changes associated with movement, it is has to be a seizure. And here movement is predominantly tremors, and seizure it is clonic jerking. And if you extend the limb and that movement stops, it is jitteriness, and if it is continuing, then it is definitely a seizure. This can affect both the side, or sometimes jitteriness can be focal also. Sorry for video quality of this movement. So here it has again a very rhythmic clonic movement. So it is not jitteriness is tremor. This is not tremor. Rhythmic jerking, focal clonic seizures. These are seizure mimics. This eyeball movement with eyelid movement, and sometimes subtle oromotor movement. This is possible in active sleep in newborn. It's very common, and sometimes it is being confused with seizures. Subtle eyeball movement.
Without a doubt, people with birthday this weekend.
This child is sucking the ET tube, but otherwise there is no eye staring or any movement. So this is a normal movement. This is pouting. The child is absolutely fine, very alert. So these are all seizure mimics. You need to be careful. So these are the important observations according to some common and uncommon etiology of the neonatal seizures. HIE, 60% of onset of seizures occurs within the first 12 hours. In most of the seizures, they occur in first day, rarely on second or third day. And almost all patients of HIE can present with subtle seizures along with clonic or even tonic seizures. So need to observe it very closely. So in ICH, any ICH like subdural hemorrhage, subarachnoid hemorrhage, interventricular hemorrhage can lead to seizures. In preterm grade 3 and 4 IVH, seizures usually occurs in first 3 days. Hypoglycemia is usually more common in the small for dead infants, and it usually presents on day 2 and 3. Hypocalcemia 2 peaks in a preterm within first 2 to 3 days, in second peak in a little later onset, and it is mostly in a term baby. In CNS infections, congenital torch infection like mainly CMV and toxo can have seizure onset on day 1, day 2, and day 3. But bacterial meningitis usually takes few days to present, maybe after a week also, but not on a day or 1 or 2 mostly. And HSV encephalitis rarely at the end of the first week, mostly after 7 days. And IEM can present at any time, usually after 2 to 3 days. Metabolites takes time to develop after we are starting the feeding. But NKH, that is non-ketogenic hyperglycemia, and pyridoxine dependency can present in a day 1. These are the list of IEM which can present predominantly as a seizure, definitely with other manifestations of some encephalopathy and sometimes vomiting kind of things. Two only benign epilepsy syndrome of neonatal seizures can occur. You need to keep in mind. So one is benign familial neonatal seizures. You need to. It is autosomal dominant in nature. Onset is second, third day. Frequency is very high, 10 to 20 per day, but it is self-limited. And prognosis for development is very good. So don't afraid about the frequency to start with. Benign idiopathic neonatal seizure. Onset is usually on the 5th day. It is for 5th day fit. It is multifocal clonic, sometimes with apnea. In majority, it lasts for 24 hours, sometimes up to 15 days. Role of anticonvulsant is still debatable. So whenever patient presents with neonatal seizures, which are the investigations you start with? So very important is CSF analysis, even with without very apparent sepsis. Whenever they present with seizures without any other apparent hypoglycemia or hypocalcemia kind of etiology, always go for CSF routine macro. Definitely good quality MRI, EG monitoring wherever it is feasible. Initially, maybe little later, and screening of metabolic disorders like plasma amino acids, cell carnitine, urine organic acids. Definitely workup for vitamin response to epilepsies like biotinidase, pyridoxine dependency. We need to look for CSF glucose and lactate for ruling out glucose transporter deficiency, which is treatable with a specific treatment. Definitely, next investigation of choice is genetic study. That is clinical exome sequencing or whole exome sequencing. Targeted epileptic encephalopathy, it saves the time in money when you are very sure you are not dealing with any other rare syndromes, only seizures, predominant findings. Then you should go for targeted epileptic encephalopathy panel. CSF neurotransmitters mainly for folinic acid deficiency, rarely muscle biopsy for mitochondrial disorders, and very high-end MRI rarely you require. Yeah, EEG is very important in a three-way. Just to diagnose electrographic seizures, it is very common in HI, mostly after loading with Gardinal or some antiepileptics, and in a premature child. So what is electrographic seizures? There is no clinical seizures, but if you monitor the continuous EEG, you can find electrical activity that is called ictal activity in the EEG. So that is electrographic seizures. Also, it is to determine the paralyzed infant experiencing convulsive phenomena because they are not going to manifest any motor phenomena. And also, it is very important to prognosticate about the future of the child. Yeah, this, as we mentioned, electrographic seizures, we need to do continuous EEG monitoring, and it is very high, treated or untreated. So you need to be careful in a patient, specifically HI. And definitely it is known to cause more neuronal injury, and that's why we need to control it with medicines. So whenever they present with the seizures in a neonatal age, with this clinical and electrographically confirmed, obviously you need to check the glucose, calcium, magnesium, you need to correct it. If it is fine, then you just go for this algorithm. Yeah, obviously ABCT, you need to take care of airway clearance, breathing, supplement oxygen if required, circulation, temperature you need to maintain in a normal range. Then you just load phenobarbital 20 mg per kg over 15 minutes, wait for 15 minutes. If there is no control of the seizures, you can load another 10, and maximum is total 40 mg per kg. You need to monitor closely respiration and blood pressure. If this is not working to the expectations, then what are the second line medicines which we use in neonatal seizures? Is phenytoin. Nowadays we have moved to the fosmanitoin, 20 mg per kg over 20 minutes. And nowadays there is a lot of literature about levetiracetam, safety and efficacy. So we load here with 40 mg per kg over 20 minutes. Yeah, when there is no apparent etiology like HI or any meningitis, and there is no response in a couple of days, even a couple of medicine is not working, always give a trial of vitamin. Definitely, first and commonest what we use is pyridoxine dependency. Yeah, for pyridoxine 5-phosphate, if they are not responding to pyridoxine, sometimes they require pyridoxine 5-phosphate. The dose of pyridoxine 5-phosphate is 30 to 50 mg per kg per day for 3 days. Foranic acid 5 mg per kg, it can present on day 1 also. Biotin commonly present in a second or third month, but it can 25% patients can present with seizures in the first month. So it is easily treatable. 5 to 20 milligram per day is the dose. Yes, sometimes very bad encephalopathy like HI or some metabolic stuff, and child is not doing well with injectable phenobarbital, second line injectable medicines, then you need to use midazolam infusion or lidocaine. We have most experience with midazolam than lidocaine. load with 0.2 mg per kg, and then maintain with 1 microgram per kg per minute. And then gradually increase till the maximum is 18 to 20 microgram per kg per minute. Lidocaine loading is 2 mg per kg. Then again you start with 2 mg per kg per hour. Gradually you can build to 6 mg per kg per hour. Nowadays, with a lot of improvement in the genetic mechanism of the many seizures, this is an era of precision medicine. So KCNQ2, these are the different mutations. This KCNQ2 mutation can present in a neonatal age. Rest of the things can present little later. But these are specific medicines which we should use without wasting the time if we have positive mutation in the genetic state. So this is a common question. Duration: how long we use anti-epileptic in a patient with acute symptomatic seizures like HI, hypoglycemic brain injury. You just examine the child. If after controlling well, child is doing well neurologically, on discharge also you can discontinue anti-epileptic. If child is having some deficit, you need to continue. You need to review after 1 month. You need to go for clinical examination as well as EEG examination. If EEG is abnormal or neurologically there are significant, there is sequelae, you still need to reevaluate and continue the treatment, and you need to reevaluate after 3 months. But nowadays, most of the people feeling shorter course of AED will be required. So again, important thing is we need to prognosticate. So which are the important things we need to take taken in consideration? First thing is etiology, like bad HI, bad metabolic stuff, prognosis will be bad. Any congenital malformations, they all will be abnormal mentally. So this is very important consideration. Yet like simple hypocalcemic seizures later onset, prognosis is good. Simple SAH, subarachnoid hemorrhage, prognosis is good. EEG is a very important tool. Burst suppression, persistent, low amplitude is suggestive of bad prognosis. In maturity, sequelae is more in a premature and very low birth weight as compared to terminal. Thank you. Now I request Dr. Siddharth Shah to start this presentation.
Right. Good evening, friends, and we'll continue with this series of epilepsy disorders. So Dr. Mehta, he just gave a very good overview of neonatal seizures. I'm going to move slightly beyond the neonatal period. So I'm going to take a very, very common topic that all of us pediatricians see day in, day out, and that is about febrile seizures. So what I did is I found out, a number of guidelines that are standard guidelines available for the diagnosis, for the management of febrile seizures, and I've listed them here. A lot of my slides are taken out from this. So if you go ahead and find out these guidelines, then you will be able to again revisit the issues around febrile seizures. So we'll start with the definition, because it is very, very important when we are seeing a patient to be able to correctly diagnose a patient with febrile seizures. So there are two definitions at the moment which have slightly different age groups and slightly different wordings, but the essence is the same. So the ILAE guideline, it states that after age of 1 month, any seizure that is associated with a febrile illness, and this is important. So it has to be associated with a febrile illness. The child could be unwell to start with, then have a seizure, and then the mother might identify that he's got a fever at that time. So that's a clear association with a febrile illness. It's not caused by CNS infection. So as we know, in the first year of life, it's important to rule out CNS infections without previous neonatal seizures or unprovoked seizure and not meeting criteria of other acute symptomatic seizures. So that would meet the diagnosis of febrile seizures. On the other hand, AAP in 2008 has given a slightly different definition, and they use the age group between 6 and 60 months who do not have an intracranial infection. So you see the emphasis. As a differential diagnosis of febrile seizures, a child could clearly have a CNS infection, and that has to be looked into, or a metabolic disturbance, or a previous history of an afebrile seizure, because it could be that this seizure has been triggered by a fever rather than being a true febrile seizure. So that's in the differential. So again, in definitions, it is very, very important, because the management of simple febrile seizures versus complex febrile seizures can be quite different, and we'll be looking at that in the next part of the talk. So if we look at the definition of complex febrile seizure, what are the features? Partial onset or focal features, prolonged duration of more than 15 minutes, also if IV treatment was used. So if IV treatment was used before 15 minutes, and that's what led to the seizure being stopped, then it has to be considered as a complex febrile seizure. Recurrent febrile seizures within 24 hours or same illness, so you've got more than one seizure happening. Association with post-seizure neurological abnormalities such as Todd's paresis, which clearly signifies a focal seizure, and that would lead you to classifying the seizure as a complex febrile seizure. There are a few other slight deviations to that. So what is a febrile status epilepticus? So if your complex febrile seizure lasted more than 30 minutes, or the child did not recover and has a series of short seizures without recovery in between, then it would be classified as febrile status epilepticus. What is febrile seizures plus? So in our country especially, where there's a huge incidence, about 5 to 10% of children present to you with febrile seizures in childhood. There are a number of patients who actually come after the age of 6 years, and that would not fall into the standard definition of febrile seizures. In that case, you would still consider this as febrile seizure, but you would name it febrile seizure plus. So just in a single slide to revisit what the pathogenesis is of febrile seizures, why do they actually happen? Your parents are going to ask you, why does my child have a seizure when he has a fever? So hyperthermia itself, so the brain being warmed up and leading to channel dysfunction, especially calcium channel dysfunction, that can lead to a seizure. Inflammation and cytokines, more recently, especially interleukin-1 beta, that has been clearly implicated to start off seizures in these patients with hyperthermia and fever. And ultimately, why does not everyone have seizures, but some children have seizures? That is because of your genetics. So a number of genes have been implicated, and the most well-studied and most well-understood is the sodium channel mutation, especially SCN1A mutation. Along with that, SCN1B and GABRG2 have also been found out. This wonderful cartoon shows, if you're at the mild end of a sodium channel mutation, you get febrile seizures. Then you can move on in severity, and there are febrile seizure syndromes. So basically, if you've got a moderate or severe mutation, you get GEFS plus. So that is, within the family, you have febrile seizures, you have afebrile seizures, or just afebrile seizures. And at the end, if you've got a very severe form of febrile seizures syndrome, then it's SMEI, which is severe myoclonic epilepsy of infancy, which is a very, very interesting condition. And children present with a combination of febrile and afebrile seizures, and the management is totally different. Okay, so sticking to the management of febrile seizures, sticking to the basics, what do we need to do? We need to control a seizure, we need to control fever, we need to rule out a CNS cause, we need to find and treat the cause of fever, because of course the fever has led to the seizure, but what is causing the fever, and that needs to be looked at. We need to make a subsequent investigation plan, so that includes investigations, admission, what happens next, does the child have seizures again, and most importantly, education and counseling of our parents appropriately, so that they don't get worried about these seizures, and explain to them why they are different from epilepsy. So I'll start one by one. sticking to the first point, controlling seizures. Why is it important to control the seizure? So like any other seizure disorder, and especially I focused on this question, does having a febrile status epilepticus, so that's a prolonged febrile seizure episode, lead to hippocampal sclerosis? And eventually this hippocampal sclerosis leading to epilepsy. So this has clear implication if the answer is yes. So there was a study and they looked at the association between hippocampal sclerosis after especially febrile status epilepticus, and clearly they could see that even there could be subtle hyperintensity in the hippocampi, and if you followed these children up, some children would develop atrophy or what we call temporal lobe epilepsy subsequently to that, and that could be refractory as well. So this is a clear association between febrile seizures and having epilepsy later on in adulthood. And that is why we have to remember that we follow our status epilepticus protocol and we try and reduce the duration of the seizure as much as possible. The second question on focus would be, does antipyretic treatment reduce the risk of recurrence? Because that implies, how you tell your parent what to do about antipyretic treatment and how aggressively to control the fever. So again, we looked at a number of studies and there is no evidence that aggressively treating the fever can lead to a decreased recurrence in seizures. Two groups and they both behave same either way. Doesn't mean you don't treat the fever. Of course, you have to comfort the child, you have to bring down the fever, but aggressively treating the fever does not stop having recurrences. Because in a way, the train has left the station, you can't break it afterwards. And a very important question, because of the differential diagnosis of intracranial infections, when should an LP be performed to rule out CNS infection? Do I LP all kids that come in through my door? No, I don't. So there are very clear guidelines. AAP 2011 produced neurodiagnostic guidelines for febrile seizures, and an LP should be performed in children with fever and seizures and who has clear meningeal signs, symptoms, or the history suggests the presence of meningitis or intracranial infection. Between 6 and 12 months, when you have a child where the immunization status is uncertain for certain organisms, H. influenza, streptococcal pneumonia, then you would of course go ahead and do a lumbar puncture because the risk of meningitis is high in these patients. And it is an option when you have somebody who's probably partially treated with antibiotics before you see the child, because again the signs could be masqueraded by this and you would need to go ahead and do an LP to prove that this is not a CNS infection. What about bloods, EEG, MRI, whatever, and what about admission and what about the long-term management? So these are very important questions when you see these children in your clinics, in your hospitals. So an EEG should not be performed in neurologically normal, healthy children with a simple febrile seizure. So I think the case is open and shut with simple febrile seizures. It's not so clear with complex febrile seizures. And actually, complex febrile seizures, we'll see at it in a later on slide, could be the first presentation of an epilepsy disorder or something intracranial. So that's why when Cochrane did a study, they could not come up with a clear answer. And I think a lot of studies are now saying that it would be reasonable to do an EEG in patients with complex febrile seizures. What about routine bloods? Routine bloods, again, CBC, electrolytes, calcium, magnesium, should not be performed for the sole purpose of finding the cause of seizure. I mean, of course, for the cause of fever, you could do your CBC electrolytes and that would help you, but not for the cause of seizure because you know that it's a febrile seizure. Routine neuroimaging, again, is not required in patients with simple febrile seizure because we know how many patients we see and we would be doing a lot of unnecessary MRIs on these children. So in simple febrile seizures, it's fairly straightforward. What about criteria for admission? So the Italian League Against Epilepsy guidelines, they give very clear guidelines. Simple febrile seizure, any child less than 18 months and first febrile seizure, you need to admit, observe, and also consider investigations for intracranial infection. If the child is stable and you don't need any further observation, child could be discharged from hospital. In a complex febrile seizure, an admission is required for observation and management, which I'll discuss in the next few slides. What about the treatment? So now in terms of simple febrile seizure, it is very, very clear, and I know we all get confused about this, what to do about a simple febrile seizure. There's a lot of parental pressure often because they are worried about seizures, but you can explain that this is a benign condition. It tends to remit spontaneously, and the recurrence rate is about 30%. So around 60-70% patients will not have another seizure after having your one simple febrile seizure. So basically, when we weigh against giving treatment and the side effects of those treatments, it is not worth giving any prophylaxis treatment. There are some special conditions, and I will go through them in a slide or so. And so this one. So when we talk about febrile seizure treatment, I said in simple febrile seizure, one seizure, you don't do any treatment. Second seizure, maybe 6 or 8 months after the first seizure, again, you don't need to offer any treatment. But if a child has frequent seizures, that is 3 or more in 6 months, or more than 4 in a year, that kind of leads to an unacceptable scenario with parents, with the amount of seizures and the worry that this could lead to something else. So in those cases, you might offer some treatment. If a child has history of prolonged seizures, more than 15 minutes, and every time he has a febrile seizure, he requires treatment, that's unacceptable. And again, remember, I talked about mesial temporal sclerosis and association with febrile status epilepticus. In those patients, you might want to consider giving some treatment. So what are the treatment options? Intermittent diazepam was trialed, and 2 doses given 8 hours apart rectally, could be acceptable. Of course, now we have the availability of clobazam, and clobazam could be given orally. So twice a day clobazam given for 3 days to cover the initial 72 hours of the febrile illness could give you a prophylaxis and reduce the recurrence of seizures in certain patients. If you tried clobazam or intermittent diazepam, and if it fails, then you might consider sodium valproate as continuous therapy. So see, the number of patients you are going to choose to give these therapies is going to be much less, as a filtering method. Phenobarb has more side effects, though it is efficacious, so not being used against sodium valproate, and phenytoin and carbamazepine are actually ineffective and should be avoided. Treatment of complex febrile seizures. In a single slide, I think when you deal with a patient with complex febrile seizure, you need to consider 3 things. Could it be a prolonged febrile seizure which has the same prognosis as simple febrile seizure? So, there's no family history around. This is the first time he's had a complex febrile seizure. He's not in the very high risk age group of 1 to 2 years. This patient could actually just behave like a simple febrile seizure and might not have a second seizure again. So that's one thinking. The second differential could be that there is an underlying acute symptomatic disorder or lesion. So you would consider this especially in focal seizures, when you have a complex febrile seizure which is focal, or you have a patient who had neurological previous abnormalities, say a child with cerebral palsy. So clearly he might have an underlying lesion which is, and the fever is triggering that seizure. So you need to investigate him differently. Could it be the start of an epileptic syndrome? So there are certain interesting febrile syndromes, epilepsy syndromes. So Dravet syndrome or SMEI, as I mentioned with pathophysiology, FIRES, or GEFS plus. So GEFS plus, again, I mentioned along the pathophysiology. So this might become clear as time evolves. The patient presents to you a second time, and then you might start thinking of these febrile seizure syndromes, and EEG might help in this scenario. So there are various things to think around complex febrile seizures. So this is just a flow chart and a recap of what I've said. So you've got a first febrile seizure, you control the seizure, you control the fever, you rule out CNS infection. Then you start thinking about no recurrences. The patient doesn't present again with a recurrence, no treatment required. Few recurrences, explain the home management of seizures, not to panic, what to do at home. And then there is this third category where patients might have multiple recurrences and have risk factors, which you would then think about intermittent benzodiazepine, and if that fails, continuous anticonvulsant, sodium valproate, as I mentioned. Okay, so another important question in the management is about iron deficiency anemia in febrile seizures. And we looked at a systematic review and meta-analysis, and quite useful. The conclusion of the meta-analysis was that iron deficiency anemia is associated with an increased risk of febrile seizures in children. especially in the Indian subcontinent. A lot of children are deficient nutritionally, especially with iron. So giving iron therapy for a couple of months will actually help your patient and might reduce the recurrences of febrile seizures. What are the risk factors? So how do you decide which child is going to come back to me with recurrences? And this is very, very important when you want to talk or counsel the parents. So definite risk factors, important to focus on that. If there's a family history of febrile seizures, and usually there is 30–40% patients will have a sibling or one of the parents or somebody in that generation who's had febrile seizures. If the age is less than 18 months of starting the seizures, peak temperature is lower and the duration of fever is lower before the seizure happens. So any of these are definite risk factors. Possible risk factor, again, family history of epilepsy instead of febrile seizures can be a possible risk factor. What are not a risk factors? Interestingly, complex febrile seizures are not a definite risk factor for recurrence. So one complex febrile seizure doesn't mean the child is going to definitely have recurrences. And what are the risk factors for subsequent epilepsy? So when the parent asks you, is my child going to have seizures again, or is he going to have epilepsy in future? So definite risk factors, neurodevelopmental abnormalities that are pre-existing, recurrent complex febrile seizures, family history of epilepsy. Now this comes into play as a definite risk factor, and the duration of fever. The shorter the duration of fever to trigger the seizure, that might become a definite risk factor. And possible risk factor could be more than one complex feature. Not a risk factor, family history of febrile seizure doesn't put you in a category of epilepsy. Age at first febrile seizure doesn't put you in the category of subsequent epilepsy either. So coming to the last part of my talk, and quite an important part. When you see these children, you manage them well, you put them into a category of what you're going to do when you send them home, but health education. And this is very, very important. So describe as much details on febrile seizures and difference from epilepsy to the parent. So the pathophysiology, why did it happen, and how is it different from epilepsy? That is important to mention. Need or appropriateness of anticonvulsant therapy. So as we just saw in the presentation, most children will not need a treatment. So that has to be told to the parents and explained why do they not need a treatment. Instructions of fever control are important. So of course, send them home with antipyretic, when to give it, maybe buy a thermometer, and how to measure temperature. All of that needs to be explained. And then if unfortunately the child does have a recurrence at home, how to manage it. So a standard management of a seizure, but also to remember, if a patient has had a previous prolonged febrile seizure, it is worth trying to prescribe an intranasal midazolam preparation so that they can use it at home and prevent the child having a second prolonged febrile seizure, which can be detrimental. So I'll just finish by putting this leaflet, and it's a beautiful leaflet which puts in 3 important questions. Is this a febrile seizure? And gives everything there, definition, simple, complex, febrile status epilepticus. Consider alternative diagnosis, and most important, red flag suggestive of CNS infection. So do not forget that. And lastly, think about risk factors, recurrences, and educate and inform your parents before sending them home. Thank you very much.
Dr. Siddharth, I think it was a very interesting session. Can I flash the polling which you have decided, Dr. Siddharth?
Yeah, let's do that, and let's see whether everybody remembered.
Yeah, so to all the participants, I'm the co-host here for Dr. Siddharth. It was a very interesting session on febrile seizures. Just give me a second, I'm launching a poll. You need to respond to it. Let's see how many percentage goes correct. And I'm just launching it right now. And you all need to vote for it, all the 184 panelists. And it's there on your screen live. I'll just put it for 10 seconds with all of you. It's in progress now. So I'll request you to launch for this, all the participants. Can you please launch it? Okay. Last 4 seconds to go. I'm ending the poll now.
So very interesting. Yes. So when is a febrile seizure? When is a febrile seizure considered a complex febrile seizure? So everything except, and I think 70% remembered beautifully that age is not a factor when defining complex febrile seizures. It tells you that this child has febrile seizure plus, but the three important factors, prolonged seizure, focal seizure, and repetitive seizure. 25% thought that more than one seizure in 24 hours would not constitute as complex febrile seizures. No, but it is part of the definition and it would constitute complex febrile seizures. Brilliant.
Thank you, Dr. Siddharth. Thanks to all the participants for sharing your thoughts on this poll. I would like to welcome Dr. Nitish for this. It was a very interesting two talks which we have just seen from Dr. Siddharth and Dr. Sanjiv. So over to Dr. Nitish, please.
Hi, good evening, friends. Thanks for joining for this fantastic academic session. And our purpose is learning and sharing. And as part of that, we had excellent two talks so far, Sanjiv bhai on neonatal seizures and Siddharth on febrile seizures. Do write down your questions or queries in the chat box. And at the end of the session, we'll be discussing those answers as a panel. So definitely we'll try to answer all the questions if possible. So I'll be talking mainly on approach to first unprovoked seizure. And it will start from some basics to advanced, and we'll try to cover something in 20-25 minutes. So what they will cover? It will cover on febrile seizure, something on first seizure, approach to first unprovoked seizure, something very basic on new ILD classification, which will be discussed in detail by Dr. Udani sir tomorrow, initial management of first seizure and how we progress from there. Very importantly, which are the worrying first unprovoked seizures? Very briefly on prolonged seizure management, also including use of midazolam nasal spray. And of course, as I said, at the end, it will be open panel discussion. So first seizure. And it's always confusing to people when we use different terms. Someone says seizure, someone says convulsion, someone says fits, someone says epileptic seizure, someone says epilepsy. Are they same? Answer is no. They all are different. They're all different. So mainly seizure is an umbrella term. It's a big term, and all the seizures can have different phenotypes or their semiology. So there can be motor part is called as convulsion. Again, it can be jerking or stiffness, or it can be just blank. And what do we mean by seizure? So whatever you're doing, it ceases. If I'm just sitting idle, I can become stiff and jerking, that's a seizure. If I'm walking, talking, and suddenly I stop, that's also a seizure. So seizure is a broad term and can have different phenotypes. Okay, different causes. So it can have epileptic seizure or non-epileptic seizure. And what difference epileptic or non-epileptic is? Epileptic is unprovoked seizure. The primary origin of seizure is in neurons with excessive hypersynchronous electrical discharge. So primary, it starts from the neurons because of discharge and depends on the part of the brain involved or network involved, can different kind of seizures. So these are epileptic seizures. Others are non-epileptic. So they also have they can have same phenotype, can have jerking, can have stiff, can have blank, can have focalized. But their onset is outside brain. So primary stimulation is provoked. So brain is provoked by the temperature, nicely covered by Dr. Siddharth on febrile seizure. Acute symptomatic we see very frequently. Hypoglycemia, hypocalcemia, head injury, syncope, they are all acute symptomatic seizures. And others, these are non-epileptic seizures. So we are talking about epileptic seizures, primary origin in the neurons, which are unprovoked. Others are provoked seizures, they are secondary seizures, and they are basically provoked, so these are not epileptic. Once someone has recurrence of unprovoked seizures, so one has tendency to have epileptic seizures, that's called epilepsy, and we have different epilepsies, and we have different epileptic seizure types. So I hope I'm very clear as a basic. What are seizures? Different seizure semiologies, but epileptic, non-epileptic, and recurrent epileptic, that's epilepsy. Some facts, sometimes we get confused. Is epilepsy very common? All the seizures are same? We discuss, answer is no. But if I say, if you have all the children presenting with first seizure, that includes all seizure, how many are likely to have that seizure, first seizure as an epileptic seizure? Someone say 50%, someone say 80%, someone say more or less. But you'll be very surprised to see it's only 25%. So of all the seizures, only 25% presents as a epileptic seizure. So of course, everything that shakes is not epilepsy. So now coming to the approach to seizure, and that's very important slide. And I want to remember the acronym DESCRIBE. For every seizure, you need to describe with a double S. And what it stands for? First, description of seizure, what it looks like it's how it starts, was there any stiffening, eye rolling, uprolling of eyes, jerking, etc. So that description of seizure. Then you decide, are these seizures epileptic or not epileptic? Next, you try to decide the seizure type. Is it focal or generalized? Ungeneralized, what it looks like, it's tonic, clonic, etc. So you define that. From that, with other information, try to say the syndrome type. We'll go into these details as well. At every stage, try to find out what's the cause, what's the etiology behind this, and appropriate investigation we'll be discussing. And very importantly, not just seizure, think for describe right, that is relevant impairment, and also any issues with behavior or on education. So that describe, and I will request you to just focus on this one slide, which is very important, and we will then move forward. So how do you diagnose whether it is epileptic or not? Is there any magic? Answer is again going to basics. These are history, and examination. So it's a clinical diagnosis. Few important parts in this part is history is very important from not family but also from child. As we know as clinician, even the younger child of 4 or 5 years can give excellent history. So make sure you try to elicit history from the child as well as family members with a detailed history. And what we mean by detail for the seizure, always start with the background, what child was doing, what was happening at that stage, and how it began. Was it face go to one side, child stops talking, or one hand started jerking? Then what's the actual event like for duration, how it ended, and what was the child, how was the child at the end of the event? So that whole event, whole things should be part of the seizure history. Sometimes by mistake what we do, we just focus on the actual event. Then बताइए क्या हो रहा था? तो क्या generalized tonic-clonic, खींच आ रही थी, झटके आ रहे थे. So that's not the actual event. Beyond that, you need to see whole history as well. Other part of history is very important is eyewitness, because in the children, mother is the most important eyewitness. So always make sure you talk to the mother and get details from her. Sometimes friends or class teacher, someone might be there who can be good eyewitness. Nowadays, everyone has a mobile. That's very helpful. Ask them to record the video if possible. And for that, again, basic things to request them. Make sure there's sufficient light there. And don't just too much focus on the child's face, but try to cover whole child. So that's a video. And eventually the pattern recognition, your experience, you know what's happening, what is what. Right? So we'll go with the example. So I'm showing two videos to you. Both the children, the history was this child has stiffening and jerking episodes. So this is first seizure. See what's happening. I will give the commentary with that. So child is sleeping, and from the sleep, child suddenly wakes up with a forced eye opening. Whole body goes stiff, and followed by whole body fast rhythmic jerking. See how fast rhythmic is. It's both hands and feet, maybe face as well, and very fast, 2 to 3 hertz fast rhythmic jerking. And this is very classical of epileptic seizure, that is generalized tonic-clonic. And I'm sure as a pattern recognition, you won't miss that. Now we have a same history. It's a teenage girl having generalized tonic-clonic seizure in the school. And what it shows? So what it shows, she's in the school, forced eye closure, more of a chest and pelvic thrusting, and very random upper limb and lower limb jerking, which is not synchronous, very slow. And I'm sure you'll be happy with the pattern recognition. This is non-epileptic, right? So both were generalized tonic-clonic seizures, but one first was epileptic and this is non-epileptic. I'm sure you're happy with that. So this is clinical diagnosis. Of course, we need investigations. Why? We need to appropriate investigation to support the diagnosis. Sometimes we need for seizure type, classification, and also for syndromic diagnosis. Also, we want to know etiology, what caused it, how it's going to do the prognosis. So prognosis is again very helpful. What are the comorbid conditions? And of course, we need help with the management as well. So this is the role of investigations. We'll go through one by one. Very helpful to us, the important tool is EEG, electroencephalogram. And for us, it's very obvious for this child with the cursor, You have some spikes, spike and slow, coming from specific part of the brain recording. So this is a focal seizure coming from specific area. And with the EEG, we can definitely help with the seizure type, focality if there is there, syndromic diagnosis, sometimes very helpful with the drug response, or even status epilepticus, what's going on in PSU especially. So EEG is very helpful tool in a safe hands. This is something what I've learned with experience is make sure EEG is appropriately done, both technically and recording wise. Also, activation process should be done as when required, like sleep, fatigue, or hyperventilation. And it has to be reviewed by someone who is expert in child neurology, because EEG is excellent tool, but it lacks sensitivity and specificity, especially so in unexperienced hand. In that case, you may lead to wrong diagnosis, unnecessary wrong treatment, medications for years and years, and their side effects and cost. So there's extra burden. So again, EEG very helpful. Now neuroimaging, and when I say neuroimaging, it's almost always MRI brain. MRI brain is the investigation of choice. If you want to go ahead with that, so initially it should be 1.5 Tesla, plain, that is non-contrast. As and when required, refractory epilepsy, we may go for 3 Tesla, epilepsy protocols and other things. But to start with, 1.5 Tesla plain MRI brain is the investigation of choice. Is there any role of CT scan? Yes, of course, in emergency, when there's non-availability of MRI, likely head injury or some trauma. And of course, when you're suspecting calcifications, like some stuck liver or tuberous sclerosis, something like that. So this is the classical 4 symptoms or 4 different patients I'll be seeing. And any of you, when you're sitting in the clinic and you're seeing epileptic seizures or epileptic patients, one of these patients will be there in your clinic on daily basis. Neonatal hypoglycemic brain injury with posterior damage, stroke, neurocystic psychosis, and tuberculosis. So these are the common MRI findings. We are not discussing in detail here. Do we need blood tests? There are no routine blood tests as such for routine first febrile seizure. But in Indian scenario, young children definitely suggest random blood sugar and calcium, because hypoglycemia is very common in Indian situation, and especially newborns, infants, hypoglycemia. We need advanced investigations, metabolic tests, CSF, sometimes such as genetic tests, panels, and specialist tests as well, as and when required, tailored according to each patient. Now, pausing here for IA new classification of seizure, Dr. Udani sir is going to take very much in detail tomorrow, but for our brief purpose here, we need to know what are generalized seizures, what is focal seizure, and then we can start appropriate medication. This is IA classification. Think for a seizure type is a focal onset or generalized onset. Sometimes you are not sure to start with. And every stage, try to find the etiology, the structural cause, genetic cause, metabolic stroke, or immunology, or unknowns. With other information in EEG and more evidence like video, you may be able to say what kind of epilepsy is. Is this focal epilepsy, generalized epilepsy? It's combined, focal with secondary generalization, or it's still unknown, and you need more evidence to suppose that. And eventually, with other supportive investigations, including EEG, try to define as an epilepsy syndrome. Again, we are not just talking about seizures, always think for associated comorbidities, describe RICN. Right? I hope you are very clear with that. What is generalized seizure? What is focal seizure? Again, almost same what we're thinking, but now we know brain works as a network. And when we have generalized network or bilateral distributed network involved from the very beginning. So this is about originating of the seizure. So its origin is generalized or focal. So when you have generalized network or bilateral distributed network, these are generalized seizures. And as we know, tonic seizures, clonic seizures, tonic-clonic seizures, atonic, melancholy, absence, etc. Focal seizures, again we're talking about the onset. So when the onset is in the focal network or focal region or focal lobe, so it starts there, propagates there in the lobe and hemisphere, and eventually it may spread to other side, but origin is focal. So these are the focal seizures. And this is again detailed classification, not going to that, I will be taking tomorrow, but how it's helpful, because it helps us to decide the seizure type, move to the syndrome type, and further management. So syndrome type in the describe. And epilepsy syndromes are specific syndromes. It's a group of conditions. So when you have specific seizure types, specific age of onset or age group, and specific EEG signature, you can define something as a specific syndrome. And how they are helpful? because they have standard treatment protocols. You know which drugs are going to work for them, which are not going to work for them. And also standard prognosis, you know what's going to happen, which are benign, which are malignant. And an example is here. So if you have a child who is 6 years with a clinically absent seizures, and I do EEG with hyperventilation, also I can see 3 Hertz generalized spike and slow wave discharges. So this is very classically spike and wave, spike and wave, spike and wave. 3 Hertz, like, so within these 2-3. So within 1 second, 3 times it's happening. So this is generalized spike and wave discharge, abrupt onset, abrupt offset. I will put this as a childhood absence epilepsy. So typical absence, so this is a syndromic diagnosis, CAE or childhood absence epilepsy. I know the good drugs, so valproate, ethosuximide, it's good prognosis, and I can reassure parents. So syndromic diagnosis is that way helpful. If you think for benign epilepsy syndromes, here are some of the age group, and as you go from infancy to toddler to adolescence, Sanjiv nicely discussed non-familiar and familiar neutral conversions and benign myoclonic epilepsy. Then benign occipital epilepsy like paniocephalus, chronic epilepsy, and later on idiopathic generalized epilepsy like CAE, that is childhood absence epilepsy, and juvenile myoclonic epilepsy. They are all benign epilepsy syndromes. Bad epilepsy syndromes are affected in sororities. In neonates, as discussed, Otara syndrome, EIE, West syndrome in infancy. And as you go, as discussed nicely by Dr. Siddharth, Dravet syndrome, that's your SCN1A extreme scenario. You can have Landau-Kleffner, other myoclonic aesthetic epilepsies, and myoclonic other progressive epilepsies. These are bad epilepsy syndromes. So you know these epilepsy syndromes, you are going to say to parents, wait, drugs are going to work, but it may control the seizures, we may have associated comorbidities, and we are not looking for great prognosis, and it's long-term course. So this is how you can help with the prognosis, treatment, and communication with the parents as well. Again, summarizing slide for the how we done with the investigations so far. So you decide your epileptic, if these seizures are epileptic or not. Try to define seizure type. This is mainly on history, clinical examination, and the help of videos, plus minus EEG in some cases. And syndromic classification with the help of the EEG, and with the etiology, MRI, other appropriate investigations, we know actually what we're dealing with, and of course try to help with the management and prognosis. I hope I'm clear so far. Because now clinicians will say we are mainly interested in management. So now come with the management. What is our aim? Our goal is to achieve complete seizure freedom. Of course, seizure is one thing, but also what we want is to ensure a normal quality of life. Again, remember, describe. We want to make sure there is no comorbidities, or if they are there, we handle them and try to give normal education, normal quality of life, and normal participation in community. So how we deal with that? During the seizure, first aid, very important. Make sure child is in the recovery position, nothing to be put in mouth, and reassure parents. General safety is required, prevent injuries, and always nothing to be put in mouth. General safety advice and lifestyle advice, of course, be safe for routine things. We should be wearing helmet anyway, but avoid high trauma like sports, rock climbing, etc. We'll be discussing on medications, how we start on antibiotic drugs. We'll be doing the basic today, and detail will be done by Dr. Anita Hegde on Thursday, that's day 3, on choosing your ADs. Very important part is counseling, because parents are so anxious, they think only 2 questions comes to their mind. Is my child going to die with a seizure? And second thing, uska nas dab jayega, fat jayega, mane ki is he going to be mad or mentally retarded? We can reassure, most of seizures last less than 2 minutes. They stop on its own. Don't worry. What you need is general safety, first aid. That's it. What they die of is mainly from the injuries, trauma. So avoid that, safety. And most of seizures, they don't last long and they don't cause that damage. So we are not talking for general, most of seizures, the brain damage or consequences. And of course, further management will be specialized treatment with the refractory epilepsy, correct diet, and good counseling skills. We will talk about that. So what are your first line ADs? This is a broad group, how you start your treatment. Details will discuss on Thursday, but this should give broad spectrum answer. So less than 3 months of age, very clear answer by Dr. Sanjiv Mehta, first line phenobarbital, second line levetiracetam, or as you wish. 3 months to 2 years. If it's generalized seizure, sodium valproate, if child is not metabolic or you don't think there is a metabolic cause, or levetiracetam for any child. Again, you can see why we wanted to know seizure types, epileptic or not, and in epileptic, focal or generalized, so you can decide right treatment. Focal seizures, oxytocin will be better. Of course, you can use carbamazepine as well. 2 years onwards, same principle, generalized seizures, sodium valproate or levetiracetam, and focal seizures, oxytocin if possible. So this is a basic layout. It doesn't include everything, but as a primary first-line drug, it covers the things. And for most of us, it will be helpful. Counseling, very important part, because parents want to know what's happening, so we reassure it's going to last less than 2 minutes, no prolonged seizures, no brain damage, don't worry. And what happens after first unprovoked seizure? Good thing, 70% will never happen again. I'm talking about unprovoked seizures is an epileptic seizure. So 70% will not happen again. Yes, 30% will have another seizure, and we need to know which are more likely things. And if it occurs, live normal life. Of course, explanation on first aid, safety, emergency contact numbers, and rescue medication. The rescue medication is very important, and we are talking about midazolam nasal spray. So when should we prescribe that? Now it's 3 conditions. We did 2 here. One is prolonged seizure. So any child who has seizure more than 5 minutes. What is serial conversions? So like 3 or more seizure in 1 hour. And third, for our scenario in India, if child is coming from area where they have difficult to access the health system, they're very far of the hospital, clinic. In that case, also, even for the shorter seizure, I will give midazolam spray. So if you're in doubt, give a midazolam spray. So this midazolam nasal spray, there are different strengths available. Most strength are 0.5 milligram per puff. Don't remember the dose as a milligram per kilogram at the moment. Simple calculation in your mind is for every 5 kg of the child weight, you put 1 puff in each nostril. So 5 kgs, total 2 puff, 1 plus 1. We are putting in alternate way. So if child is 7 to 10 kgs, you put 2 plus 2. 1, 2, 3, 4 puffs. 12 to 15 kgs, 3 plus 3, and as on. So you know the dose now. So midazolam nasal spray, the dose in the 5 kg increment, and technique is very important. So always ask parents to get familiarized with the spray. This is I'm showing here. It's a nasal spray, and how you use it. You make sure child is in sitting or semi-sitting position. You cannot insert into lying down position. So child should be in sitting or semi-sitting position. Make sure they have used this before, and they do priming. So remove the cap. Priming is you just press, make sure the air comes out, and then the spray comes. You can see nicely spray is coming out now. So now then you put the puff, each nostril 1 by you, and you know the dose. 12, 13 kgs, that is 3 plus 3. Alternate 1, 2, 3, 4, 5, 6. And cleaning very important. The plastic part after you should be using a liquid bottom to make sure it remains clean. Now, very important discussion, something on wiring first epileptic seizure. And I will request some my colleagues to put the poll here. So
yeah, thanks, Dr. Nitish. I think I'll just put the launch poll here. It was a very interesting session on the describe and the management. I'm just launching the poll to all the 173 panelists. That will be shortly coming to you on the screen. And I'm just launching the poll now.
it's something on, yes. When a child presents with first unprovoked seizure, which seizure type would be the most worrying to you? You can choose one more. Let's start.
So last 4 seconds, Dr. Nitish, for me.
Yeah.
And I'm just ending the poll now. Yeah, okay, 20 seconds up, time up.
Okay, great.
So that's it. Over to you, Dr. Nitish, now. That's the results for you.
Yes, I think most of this, all of above, and there are some concerns for specific person. It depends on expertise and where you're working. But I totally agree. I totally agree that all of above is. And if I translate here, so epileptic seizure type with high recurrent risk, difficult to control, associated comorbidities, or associated mortality will be worrying you. And if you translate more here, which are first epileptic seizures, it's the first afebrile seizure after prolonged and focal febrile seizure. It's a Dravet syndrome very well covered before. Symptomatic epilepsy, and what do we mean by that? Someone has abnormal development and or neurology to start with. Prolonged seizure status epilepticus, of course, will be worried. And specific seizure types, we'll be discussing few minutes here on specific seizure types. So in summary, if I say if you're absent seizure, myoclonic seizures, atonic or spasms, even they present with you as a first or so-called first unprovoked seizure, when they present to you, they would have at least few episodes before. So when they come to you, they already had few seizures before, so they are not first. So you always treat them, and they are usually associated with the bad prognosis or epilepsies. Few simple examples. This is atonic seizures. The child is like sitting. For a fraction of a second, child will have loss of current or loss of tone for a fraction of a second. And that's miserable life. In miserable life for this patient, these are atonic seizures and difficult to control as well. Myoclonic jerk. Just focus on the elbows here. Elbows. You saw that. And I usually say, if you blink, you miss. That's a myoclonic jerk, because patients usually don't come with a presentation unless you ask them. So I'm presenting again. It's very brief, subtle jerk, and awake position. That's it. That's myoclonic jerk. Epileptic spasm, we all know it's 2 to 3 second seizure. When you have chronic stiffness, so it occurs as a recurrence, clusters from sleep, and that's waste syndrome. An absent seizure with classical and blank, and that's absent seizure. So these are seizures. Be careful of. Be careful of. Very few slides quickly on prolonged seizure management. I'm not going to detail of status management, but when you have a child with a seizure status, prolonged seizure, always think for Virat Kohli. And the reason I'm saying Virat Kohli is when you're in crisis, you need a base batsman who plays a base shot, who hits early, hit hard. Seizures, epileptic seizures, the status is medical emergency. We want to make sure we have base medication, base dose, base drug, and hit early, hit hard. Because first 5 minutes are first aid, but beyond 5 minutes, wherever you are, depends on the child. Call the ambulance or use the rescue medication or start status management. Because initial temporary systemic changes from the brain and body, as the time passes, you have life-threatening systemic changes and eventual death. So you want to make sure you hit early, hit hard to remain early. This nice algorithm, I'm not going to detail, but salient points only. Initially, stabilization, airway, breathing, circulation, blood, sugar, etc. you're doing. First line is 2 doses of benzodiazepines. Benzodiazepines, 2 doses. You can give community midazolam spray and something IV once you get the IV access. After 2 doses, still going on, use phenytoin or first phenytoin, sodium valproate or levetiracetam. Doses, you know, 20 mg per kg, slow infusion or 20 minutes. And you can go on an intubation. So it's standard protocol, and make sure you're using very rigidly. But some salient points for seizures. Hit early, hit hard, it's a medical emergency. You don't want to create injury to child's brain. Use a base drug, base route, and base dose. So use appropriate dose, no half loading, full proper dose. So it's lorazepam is better than midazolam, than diazepam. Route wise, we know IV is better than IM, then nasal, then rectal. And midazolam, if you have something, even you can do IM if you don't have nasal spray or if you don't have IV access. Phosphate is better than phenytoin, even which can be given intraosseous as well. Febrile status, if you have febrile status, sodium valproate is better option. And in future, if your child is SCN1A spectrum, try to avoid phenytoin in future. And every child with prolonged seizure should have take-home midazolam spray. My last slide, that's my summary of the talk, is describe is the key. And that's very important. We know and we describe each and every seizure, classify, and try to come to the proper diagnosis. After first unprovoked seizure, 70% will never recur. But now you know which are the first seizure to be aware of or be careful of. First aid safety are very important. The counseling is essential for that. Rescue medication, midazolam spray. We discuss the spray and how you can use it and a general dose. Status epilepticus, hit early, hit hard, and why it's important. Good thing is 2 out of 3 epilepsies can be cured by appropriate diagnosis and management. So that's a key. That's a reassurance. It's not lifelong medication for majority. And majority live happy, healthy, normal life with good education. I would say thank you very much to all of you for patient interaction. And thanks for the sponsors, thanks for you guys. And in next few minutes, we'll be starting our panel discussion. While we're doing that, I'll just put so while we are getting ready, I'll just screen share these things and to remind that we have day 2, that's tomorrow. Dr. Udani sir, will be talking about the ILE classifications, nice video sessions. Dr. Anita ma'am with the decision making on choosing the AEs, and Dr. Lokesh Lingappa on final frontier on the drug resistant epilepsy. So do join daily 6 p.m. and that's in front of you. Right. So we are ready with the panel now.
So, doctor, we have a lot of questions on the chat box. I'm Samir here, and you can see the chat box and respond accordingly for this. So, can you see the chat box, doctor?
Yes. Now we have as a team we had time to do the chat box.
Yeah. So, so all the 3 doctors, please, Dr. Sanjiv, Dr. Siddharth, and so all the participants, all your queries now will be taken care. And all your questions, I can see a lot of questions coming in the chat box now.
So we are starting with Dr. Sanjiv Mehta.
Yeah, we have sorted out questions and we are answering one by one. First question to me was like EEG correlate needed specifically for subtle seizures. Yeah, subtle seizures is more common with, as I told, in patients with HIE encephalopathy and preterm patients. When you want to target each and every subtle seizures, we need to, if possible, we need to go for continuous EEG monitoring. So if then and then sometimes we can solve the problem of confusion, and then we can treat aggressively. Otherwise, unnecessarily.
Sir, your voice is not audible.
Yeah. Yeah, so it is required to confirm subtle seizures if possible, because sometimes unnecessarily we over-treat the patient, that is also harmful. If we don't recognize it, if we don't treat, it can be neuronal injury. So wherever it is possible, go for EEG monitoring, and then you treat aggressively accordingly. How to identify or confirm benign seizures? In neonatal age group, as I mentioned in my presentation, only a couple of benign epileptic seizures, neonatal seizures or epileptic seizures present. There is benign familial infantile seizures that can present on second, third day, and sometimes cluster for a few weeks, and then it is a self-limiting and it recovers on its own, and prognosis is good. Another is fifth day fit, which is not familial, and usually lasts for 1 day to 10 days, and again self-limiting, so no issue. So these are the 2 syndromes we need to define as a benign neonatal seizures. Another question is, what is the role of amplitude integrated EEG? Yeah, it is very good tool to have when you are dealing with a lot of neonatal patients who are present with HIE or bad epilepsy syndromes, or even bad etiology like developmental malformations or inborn metabolism. Because it helps in 2 ways. It helps in prognosticate the child's condition, depends on etiology, so we can prognosticate, and sometimes we can identify subtle seizures, electrographic seizures, but there is some limitations as compared to continuous EEG. But definitely it is a very good tool to have when you are dealing with frequent neonatal patients present with different encephalopathy and lot of seizure burden. So it is better to have this tool in your armory. Another question is availability of pyridoxine and biotin. Pyridoxine is available oral as well as injectable. Injectable form is like Optineuron, very famous brand, which contains 100 mg in 3 ml. Oral tablet is that is Binadon, it is 40 mg, and B long, that is 100 mg. And biotin is available in many brands. Zubitin from Intas, BTN 5 and 10 mg tablet is available. Another question is what is PLP? That is pyridoxal 5-phosphate. It is a pyridoxine dependent seizures like, but they don't respond to pyridoxine. There is a deficiency of P and PO enzyme. There you need to give pyridoxal 5-phosphate, which is active from pyridoxine, and it is available with difficulty, but it is available on Amazon. If you type pyridoxal 5-phosphate tablet, it is available 500 mg strength, and Tetrafol Plus is available, but it is a composition of a couple of other vitamins also, but only 15 milligram, 15 milligram is available in Tetrafol Plus, which is from Sun Pharma. Another question is touch-provoking seizures. Touch-provoking seizures are two conditions. One is we say reflex seizures, which is epileptic, or we can confirm with EEG, and another is non-epileptic phenomena. That is called hyperexplasia. If you stimulate on the tip of the nose or on the on the forehead, they provoke the seizures, kind of a movement. So that is called hyperexplasia. And last question, at least for me, what is the follow-up of neonatal seizures, specifically acute symptomatic seizures like HI, hypoglycemia? As I mentioned, still most of the guidelines says if child is normal neurologically, you can discharge without any ongoing anti-epileptic medicine to continue. But there is neurological examination is not normal, child is not normal. Definitely you continue your medicine, and mostly we continue phenobarbital, not phenytoin, because it doesn't have good linear kinetic in newborn. So we don't use phenytoin on follow-up. Definitely use phenobarbital or levetiracetam. Either of you can use it. And you need to follow it 1 month. Neurological examination is normal. Do EEG. If it is normal, then definitely do discontinue. Otherwise, you continue the same medicine and again reevaluate it 3 months. But most of the people are now going for a shorter course. So this is the follow-up of neonatal seizure patient. How to deal with it. Yeah, I invite Siddharth for his questions.
Right. So yes, it's been in general a very interesting session, and I hope all the participants have enjoyed. The questions have been flowing in, so I can see the enthusiasm there. We've selected a few questions, and so for my session, I've divided them simply into 2-3 parts. One is there are a lot of questions still about diagnosis, and especially about febrile seizure plus. And I think that's quite appropriate because we see the range. We see children who present to us even with the first febrile seizure after 6 years of age. We see children who have had a seizure at 1 year of age, nothing for 5 years, 6 years, and then end up having a seizure. So all these scenarios are possible. I think if we still stick to the diagnostic criteria of having an association of a febrile illness, also ruling out the other possibilities, intracranial infection, previous neonatal seizures, previous neurological abnormalities, I think we still would classify all those seizures as febrile seizures or febrile seizure plus, depending on the age. So one of the questions was, do febrile seizure have to be required to have an onset before 60 months of age? So that's your 5 years or 6 years to classify as febrile seizure plus if there was a seizure afterwards? No. So the answer is no. You can still have your first febrile seizure even after 6 years of age. I've read that even in adults, there's a small percentage where fever can trigger a seizure. Treatment of febrile seizure plus for child presenting at 7 years of age. I think it still remains the same, sticking to the same principles. If the child looks fine, the background history is clean, and it was fever-associated illness, you might not want to do any investigations. If the parents are very anxious, maybe there are recurrent seizures, you might consider doing an EEG test. One of the interesting questions was, how can we differentiate fever-triggered convulsion, so that's your epilepsy, versus first complex febrile seizure? And I think it can be very difficult. So I'll take the example of Dravet syndrome, which we mentioned a couple of times. So in this, the first seizure could be a complex febrile seizure in an otherwise normal child, or maybe a mild developmental delay. And it would be extremely difficult to tell on the first instance that this is Dravet syndrome. Maybe when the child presented again after a few weeks with a prolonged seizure, 2 prolonged seizures makes you think that this is something else. Maybe if the child has had a history of neonatal admission, neonatal seizures, and developmental delay, and then presents with a fever-triggered seizure, then you could be slightly more sure that this is heading towards epilepsy, or this is what we call a fever-triggered seizure, and you could investigate and fulfill the diagnosis. I'll move on to the diagnosis part. Somebody's asked, what about an LP in a patient below 6 months of age if sepsis screen was negative? Well, I think below 6 months of age, you would have an extremely low threshold to do an LP. And in fact, a sepsis screen includes an LP in a child who's below 6 months of age, because of the worry that we will not identify signs and symptoms suggestive of meningitis or intracranial infection. So go ahead, do an LP and complete the sepsis screen. I'll come to the last few questions, and those are around the management of febrile seizures. So role of antipyretics and role of clobazam. And I think they are very reasonable questions. We did cover them in the talk. So again, keep it simple. If it's a simple febrile seizure in an otherwise normal child, you can be very sure that there's a low evidence of recurrence and they are benign. So reassure the parent, reassure them, and do not start any anti-epileptic treatment, even intermittent or continuous. If you have children with complex febrile seizures, or as I mentioned amongst the guidelines, more than 3 seizures in 6 months or more than 4 seizures in a year, it starts becoming unacceptable, and there might be a worry that it might cause some harm to the brain, which might lead to subsequent consequences. In those cases, you could consider intermittent clobazam. And when to give anti-epileptic if we do start continuous anti-epileptic? That's my last question. If the intermittent clobazam fails and still you are having a child who has recurrent seizures, investigate. Think about the diagnosis. Is it febrile seizures or is it one of the syndromes? And if needed, you start sodium valproate. Again, the duration has to be shorter than patients with epilepsy. You're trying to cover a risk period. You're not trying to treat the patient's epilepsy or seizures. So give it for a fair amount of period to cover the risk. And then once you are confident patient is not having seizures, take them off as early as possible. Thank you. I'll hand it over to Nitish now.
Nice to see enthusiasm going on and lots of questions. And I'll start with so let's say if it's first unprovoked seizure with normal birth history, normal development and examination, no focal deficit, do you still want to go for MRI brain? Answer is depends on where you are, but there are 2 conditions I'll be always worried of. One is so-called normal birth history or some delayed cry. So neonatal hypoglycemic brain injury is a very common thing. We present as so-called normal birth, maybe some feeding difficulties, but they present later on with the seizures, and when you do MRI, you see good going oxybate gliosis. So yes, I am worried for that. Second thing, if you are in the especially northern belt of the India, where you see lots of NCC, neurocystic sarcosis, where again you can have normal examination, etc., and still can have focal findings. So if you are thinking of these 2 conditions, I will definitely go ahead with MRI, even with the first seizure. And if it's recurrent, definitely I will go ahead with the MRI anyway. Second question is same with the MRI. So any reason why we don't want to do MRI epilepsy protocol from the very beginning instead of regular MRI? Answer is it's based utilization of the resources. So if we do standard 1.5 Tesla MRI plane, it usually picks up most of the pathologies. And then when you are finding something unusual, you are looking for focal cortical dysplasia or something, then you want to focus on specific area. Because what your radiologists want is they can do 3 Tesla MRI, they can do epilepsy protocol, but then you have to decide and give them specific area. Suppose I'm looking for right frontal lobe or left temporal region or specific region from your expert's opinion that seizures are coming from. And there if you do 3 Tesla epilepsy protocol, which will be much more appropriate. But that's a best use of resources. But of course you can do anything as you and patient decide to do. It says, is ethosuximide available in India? Answer is yes. So ethosuximide syrup, liquid preparation is available. It's called as Epsons, and it comes as a 500 mg in 5 ml solution. So it is available in India. Not widely available, but it is available. Other question is, maximum number of doses of midazolam puffs. So if it's 0.5 milligram spray, I would suggest you can go up to 12 puffs, that is 6 plus 6 in a big child who is more than 50 kg or like adult size. So you can give up to 12 puffs at a time, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 6 plus 6, and it can be repeated after 5 minutes if required. But I will suggest always parents, if you're using 2 times, you need to contact medical services that you're not getting the tool with the 2 second loading with second dose of midazolam as well. The question is, first presentation of myoclonic absence or long seizure, would you start AD? I think I'll bifurcate this question. First, a myoclonic absence seizure or myoclonic aesthetic epilepsy. I will do start management, but I'll make sure I do appropriate investigations. So there's a blood test, EEG to confirm syndromic diagnosis, MRI if required. And then, yes, I will start even after first seizure. So I will definitely start with the first seizure, especially again for absence. I don't want child who has 5-10 seizures in the past which were not recognized, because when they present with the first seizure to you, they already had so many seizures in the past from last few months, and then accidents, falling behind in the education. So I'll definitely start the ADs with the appropriate investigations. Status epilepticus, I will not start long-term ADs, but yes, I will start short-term AD, which are loaded. It may be sodium valproate or Levestam, and then depends on the what's neurological outcome. Maximum up to 3 months I may continue and stop after 3 months. But after 3 months, I had to be very clear, am I dealing with epilepsy or not? But I will not give long-term AD for status epilepticus unless I don't. So it's necessary. Does it differ if seizures in sleep or awake situation, or we are single or cluster seizures for the investigation management? I think it raises lots of concerns for the family if we have seizures in the sleep or clusters. So even if the first unprovoked seizure is a cluster, it's a multiple seizures. So I'll definitely work on that and start medications. Night seizures, I think classical example I can take is a Rolandic epilepsy or Bach's benign epilepsy with centrotemporal spikes. And here the discussion should be with the family on the safety, sleep hygiene, and how good or bad they can cope with the situation. If Rolandic epilepsy, night seizures, they're not that frequent, child's neurology is normal, education is normal, and we know the trigger, that's a sleep deprivation leading to that, then we can use clobazam when our child is unwell or sleep deprived. Say second scenario, when you have frequent Rolandic seizures, epileptic seizures, I will start seizures, I'll start the medications. Or if parents are so anxious, there's family history, or someone had died or something and they're so anxious that they're not going to sleep for whole night and going to just see the child as a hawk. Every minute child moves, they want a seizure, it's epilepsy and lots of panic. In that case, I will start medication. But with a clear discussion with the family, this is more for your anxiety we are giving, may not be required. So again, everywhere, counseling is a very crucial part. And I think there are a few other questions as well, but I think we are running out of time. So I think here I would like to stop the question answer session. And again, thank all the partners and friends. To start with, we are friends, and then we become partners, and we always remain friends. That's Dr. Sanjiv Mehta, Dr. Siddharth Shah, and me. Again, whole RICN team who has helped us in building up this thing. Of course, to Sanofi, who helped us with all this presentation and IT and everything. And our esteemed faculties. We are still waiting for excellent lectures. Tomorrow, day 2, it's Dr. Rajesh Udani sir, Senior Consultant Pediatric Neurologist and Epilepsy Specialist from Bombay on diagnosis, seizure classification, video on mimics, etc. Then Dr. Anita Hegde, another Senior Pediatric Neurophysician and Epilepsy expert from Bombay, she'll be talking on AEDs. So how and what you choose and different newer AEDs, etc., etc. And if you're stuck with all of those things, Lokesh Lingappa on Friday will be discussing about refractory epilepsy approach and what can do. So it's same login ID and same password, time remains same, that's 6 p.m. And I would say thank you very much again. Thanks a lot.
So thank you.
Please.
Recording is done.
Yeah. Nitish Shah sir and Dr Sanjiv Mehta for a very nice deliberation for today's talk. Excellent talk, and we have seen a lot of questions which was very interesting and very nicely addressed upon by all of you. On behalf of Sanofi and RICN, I would like to thank all the attending doctors for a variable attendance, and this session is going to continue tomorrow, day after until 29. We request all of you to please join at 6 p.m. Very interesting topics next 3 days by all the national faculties. So we are the makers of Frisium and Valparin syrup and Valparin chrono. Thanks for your overall faith on the products, and let's see tomorrow what best we can learn from Dr. Brijesh Udari sir. Thanks to all of you. We'll close, sir.